Hello, everyone. Welcome to today's webinar, and thank you for joining us. I'm Annie Robitaille. I hold the Commissioner Ottawa Research Chair with the Centre of Excellence in Frailty-Informed Care at Pearly Health, and I'm also an Associate Professor at the University of Ottawa with the Interdisciplinary School of Health Sciences. Today's presentation is entitled Implementing Patient Navigation Across Hospital and Community Setting. Following today's presentation, there will be some time for questions. You can ask your questions by writing them in the Q&A box at the bottom of your screen. We will do our best to get through all of your questions. We also ask that you take a minute at the end of the webinar to complete a short survey that will appear on your screen when you exit the webinar. Today's webinar will be recorded and will be made available shortly after the webinar series on the Pearly Health Center of Excellence website. So I am so delighted to introduce Dr. Kristina Kokorelias, an expert in aging and geriatric care, and also a valued colleague of mine. So Dr. Kristina Kokorelias is the program manager for the Department of Medicine's Healthy Aging and Geriatrics program at Sinai Health and the University Health Network, and she's also a research associate with Pearly Health. She holds a status appointments as assistant professor in the Department of Occupational Science and Occupational Therapy at the University of Toronto. Additionally, she is an associate fellow of the National Institute on Aging. Dr. Kokorelias' research focuses on understanding the evolving experiences and needs of family caregivers and older adults with complex care needs. Her work aims to develop, evaluate, and implement timely, family-centered care programs and services. She earned her PhD from the Rehabilitation Sciences Institute at the University of Toronto and completed postdoctoral fellowships in implementation science and Alzheimer's disease at St. John's Rehab Sunnybrook Health Sciences Center. Please join me in welcoming Kristina to share her important work.
Perfect. So thanks for that kind introduction. So as alluded to, I'm going to be presenting some work that I did over at St. John's Rehab, and thrilled to say that this program is still up and running, which is why I think it is still of great value, and hopefully can be translated across sites. So, as many of you may know, many provinces across Canada are trying to shift health services from institutions to community care. And a lot of this work is inspired by some of the Scandinavian countries where we're seeing that flip in budget. So, whereas in Canada, most of our healthcare dollars actually goes to costly institutions, whether it's long-term care institutions, hospital care, etc. Other countries spend more money in home and community care. And the reason provinces are trying to start shifting towards this, or at least delivering services more so in community, is because this aligns with where most people want to live and do live. And so in my bio, we talked about this idea that a lot of my work tries to help the needs of complex patients. And so when I use this term throughout the presentation today or in my own work, I'm not necessarily talking about patients with medical complexity. I'm more so talking about patients with mixed physical, mental, and social healthcare needs. So these can be things such as spiritual needs, financial needs, physical needs, mental needs, all occurring at the same time, necessitating very specific and unique healthcare need services. And if anyone has looked at the news as of late, there were many negative but also positive experiences for patients as they navigate the Ontario healthcare system. No surprise, we hear a lot about barriers to care, particularly right now we hear a lot about emergency departments and people waiting up to 20 hours for a bed. But there's also a real highlight in equity issues where people, particularly in rural communities or of different minority groups, linguistic and racialized communities, seeking the most barriers or experiencing the most barriers to care. And patients are really desiring better services, but also better communication about their services. So things like how long are we expected to wait? What services are available? Who am I going to see? What healthcare providers are available to me? We're also seeing a big shift towards coordinated and connected care, where people are getting tired of visiting one healthcare provider, going to another healthcare provider, and really sharing their whole story, their whole situation, and the providers don't really seem like talking. And so we're really starting to see people wanting and demanding timely and smooth transitions between care settings. So, for example, if you go to the hospital emergency department, what's that experience like when you transition back to home, or you have to see one medical provider and then say see another? And there is the comprehensive range of services. So not just healthcare, the way we typically think about it, but what mental health is available, what social care services are available. And so at least here in Ontario, we've shifted towards what we call Ontario healthcare teams. And so the Ontario government tried to build a connective healthcare system that's really centered around patients, their families, as well as their caregivers, both family caregivers, but also healthcare providers. And so these changes were intended to make it easier to navigate the system and strengthen local services. So as you can see, filling in some of those gaps that we keep hearing about. And the goal of the Ontario healthcare teams is to work together to take the guesswork out of those transitions in care, because we know that's when patients feel very lost or unsupported. So instead of the current state or the previous state where you would have different healthcare providers, different mental health providers, long-term care, etc., and then the patient being the core value, Ontario healthcare teams essentially try to form a group where all these different service providers, care providers, organizations are all linked in a team where the patient and their family is kind of at the center. So the patients receive all their care from that one team. And so the vision for the Ontario healthcare teams is still ongoing. We're still seeing this being rolled out and evaluated, but the goal is to have coordinated continuum of care within a region. So depending on where you would live in a particular part of the province, you would be assigned to a team, and that team would provide all your care. Eventually, the goal is to have 24 access to coordination of care, navigation services, and ensures that seamless transition between providers, between healthcare settings, etc. And so a big focus of the Ontario healthcare teams is that focus on the quadruple aim. So the quadruple aim is is a healthcare aim where you want to have improved patient outcomes. These can be clinical outcomes, improve patient experiences such as satisfaction with care, lower cost of care, and then improve provider experience. And this has become particularly important after the COVID-19 pandemic, where we were noticing and continue to report on a lot of provider burnout and moral distress. So the Ontario healthcare teams aim to incorporate measurement, quality improvement, and continuous learning so that they can continue to try to meet this quadruple aim. And then a big part of the Ontario healthcare teams is still trying to figure out leadership, accountability, and governance. So when these teams first kind of were rolled out in the province, the government didn't really specify any type of guidelines that the teams really had to follow. There was just guidelines around, who should be in this team, what's the formation of the team, the notion of patient and family partners, but it was really left to each own team to determine how to finance, how to lead the teams, and how they would be held accountable. So, as I said, the typical patient experience, despite this improvement, is very fragmented. So, as you can see here, and unfortunately, I think many of us in the audience might have experienced this, but you essentially go to the hospital, something happens, you might not even have a primary care provider, so you go to the hospital and you get admitted. While you're there, we don't really know how to identify your complex care needs. We don't really know too much about who the other providers you see are. We're really depending on patient narratives to tell us. Sometimes families help fill in that gap. And very often do your primary care or your community healthcare partners know that you've been admitted or when you've been admitted. But what would happen then is we would start building or notifying your circle of care. So that might be your family, that might be people within the hospital network. So we should start trying to build your healthcare team, so to speak. And you might start connecting after you've been admitted to those various providers in the hospital. And again, we hear a lot about people repeating the story every time a new physician comes in, a new nurse comes in, etc. So there's multiple touch points. Each person is doing kind of their own assessment. You'll continue to get some acute treatment, and there's a lot of care planning. There's a lot of duplication, a lot of the same types of information being related. There's a lot of waiting. And then there's a lot of underutilized team members. So sometimes people, especially our allied health, like social work, occupational therapy, physical therapy, might come into the conversation what they feel is a bit too late. When you kind of stabilize and remember that the goal is to get you out as quickly as possible, we would determine that you're ready to be discharged. You would receive your instructions, and essentially you would start leaving the hospital with any or often a lack of communication with any previous assessments done. So a lot of patients often don't know kind of the results of what was happening, who kind of knew those results. Those results kind of stay in the hospital system, the hospital electronic medical records, and you're left on your own devices to leave the hospital. So you're safely discharged and you don't really know who to communicate to. It's often up to the patient or their family to tell their primary healthcare providers, their community care providers. And basically, this lack of communication and coordination often leads to readmissions, or you end up back in the emergency department because you don't know where else to go. So, when I was a postdoc over at Sunnybrook, and again, this was during the pandemic, the goal was that we would kind of change this model of care. And the goal being that none of this experience fits with that quadruple aim that the province is trying to aim. Nowhere along the lines are patients feeling very well supported. They're having those poor outcomes. Their providers are very stressed and feeling unprepared to care or unsupported in the way that they want to care. And of course, this is costly because patients are ending back up in the hospital. And at the time, Sunnybrook, to paint the picture, it remains a large academic hospital. It's one of the two trauma centers in Toronto, Ontario. So it's a very large hospital, caters to a large and diverse population. And they were experiencing extremely high volumes of older adults coming to their hospital, being discharged, and ending up right back. So this was a really unique time where, especially during the pandemic, we wanted to keep people out of the hospitals and really keep them for those emergencies as much as we can. And so the hospital really tried to create an integrated transition models that supported patients in their neighborhood. So they started investing more into putting providers like social work, working with community providers. So when a patient came in, telling them, here's where you can go in the community. And they really did this to try to provide community or continuity of support to their most complex patients. So they tried to do things like connect to a primary care provider, connect to home care services, etc. But as you could imagine, this was during a particularly big healthcare crisis where a lot of these services were already strained. And they wanted to design a transition models that looked out patients throughout their journey so that people could be sustained at home. So if we took really good care of you in the hospital, we gave you the right resources. When you go home, you knew exactly what to do. And the goal was to reduce the time that patients, families, and caregivers were really spent searching for this information. So a big focus of the hospital was we will give you the information, we will tell you who to call, who's seeing primary care patients, etc. Now, the biggest gap was they really wanted to start supporting patients to know who to call when something happened or that they needed to access service. Because as you could imagine, the last thing a lot of these patients wanted to do was end up back in the hospital during such a scary time like COVID. They were afraid of getting conditions. They were also hearing on the news to avoid clogging up emergency departments. So this was kind of Sunnybrook or as an institution's goals. And when we start talking about implementation science, you'll see why this becomes very important. So with that, I came in as a postdoc and started thinking about the goals and seeing what the literature was saying about novel models of care. And so I really had, with the team, a future vision. And the future vision was to build on those goals, but instead of just providing information, having one patient navigator that would stay with the patient and work with the patient in the hospital, but also out in the community when they leave. The goal was to have one common and accessible assessment, accessed and trusted by the broader care team. So again, the patient would only have to do one assessment. The whole team would be able to see that assessment, and that assessment would follow them out into the community. And that only one care plan was available, and the full circle of care would be able to see that plan. So that meant family would know the plan, community would know that plan, primary care would know the plan, and all the providers in the hospital would know that plan. So they all would be able to collaborate and know what the end goal was. So it was a fairly ambitious goal, but as you could see, it did fit nicely with some of the ideas that the hospital did have. And so we kind of put on our thinking caps. And of course, this began with a lot of systematic reviews going into the literature, seeing what was happening, and a lot of brainstorming sessions. So we did a lot of co-design sessions where essentially we would all mask up and rent out the biggest auditorium we have and have maybe 4 or 5 care leads with huge microphones at different stages of the auditorium and start brainstorming. What would this look like? A lot of Zoom meetings and a lot of coordination with some existing community centers, particularly Sprint Senior Care, which is well known in the Toronto area where the hospital was. And so what was determined is that the navigator would need to do certain things. The first would be that they would navigate and coordinate the services. So instead of the hospital or the providers handing a patient a list of who to call, the navigator would take care of that while the patient was in the hospital, reducing a burden and making sure everything was in place. The second is that, again, instead of leaving it to the patients and families to identify and engage and communicate with their circle of care, the navigator would do that. So the navigator, when someone new would come into the room, would be able to have already briefed them. Likewise, when the patient went home, the navigator would already have reached out to their primary care provider, spoken to them, etc. The navigator would also start thinking about the needs and the barriers for transition home. So while the hospital's goal is to get you out as quickly as possible, the navigator would start thinking about what are some of the challenges that are going to happen when this person is home. The navigator would then facilitate care planning, and they would partner with the other agencies to deliver that care. And they would coordinate and deal and lead daily huddles. So they would be that center point of communication and communicate with the hospital, all community partners, and be that one person who's kind of streamlining the goals of care, communicating about patient needs, any concern, and again, reducing that burden from patients. And if anyone's ever been really sick, the last thing you want to do is keep repeating yourself, trying to remember everything. And they would collaborate and build relationships so that they can be the key contacts. So again, if someone in the community needed to know something about the patient, etc., it wouldn't go to family or the patient, it would go to this navigator. So again, very ambitious goals, but when you think about it, a lot of this just made sense. And a lot of this is what patients and families are already doing themselves. So to relieve that burden off them, it would be the specialist role. And the goal is to integrate the patient and family as well with the healthcare team so that the patient and family is at the center. So instead of taking away just burden from the patients and families, they're instead allowing them to be integrated into more of the aspects of care that they want to be in, such as determining when they're ready to go home, just taking part in their care treatments, any rehabilitation, any instructions that they have, being able to ask questions of the different providers, and the navigator would help them try to get answers, connecting them to their broader community, etc. So we developed what was called the Senior Care Navigation Pilot. So we took all those lessons and we thought, let's try this. And so we hired a patient navigator. This happened to be a social worker with a lot of experience in the community who had never actually worked in hospital, but believed that they were the right fit because they had gone into so many seniors' homes with complex care needs. And as they described, in a hospital, everyone is kind of has the most support they'll ever have. They felt that because they knew the home environment, they knew how to improvise, they would be the best fit across both settings. This was someone who was very keen to try out a new role, held leadership positions, and was willing to adapt to change. So, with that person hired, with all our consultative exercises, we developed a new care path model. The goal was when the patient would come into the hospital, they would get an assessment by the navigator who would determine the patient complexity. And again, defining complexity not necessarily in medical terms, but in terms of complexity of how complex we're meeting all their various needs. We would identify the navigator best suited to them, and unfortunately, we only had one. And that navigator would build and notify the care team, just like what would happen normally, but there would be one shared assessment. So this patient would get their full medical workup as needed for their care, and that assessment would be shared to everyone who's appropriate. And then what's unique is highlighted in green. They would initiate a collaborative care plan. The patient, their family, and all their healthcare providers would contribute to this care plan. So everyone was talking, there's nothing of surprise, and everyone would understand the goals of the plan. And the goals would often have to meet the patient's goals. So some people were in pain management rather than treatment. Some people's goals were to get home faster or to avoid rehabilitation. And they would finalize and implement that plan. Treatment would continue as normal. We would again determine when this person was ready, and this patient would go home. So all those steps kind of are standard quote. Nothing would change. The goal was not to keep them in hospital longer. But the difference being is that the navigator who was with them almost from the start, who was involved in that care plan, would then support their care coordination into the community. This would mean calling the different providers, ensuring things like home care were already in place, ensuring that the caregivers were supported, etc. And then it would be up to the navigator to determine whether the patient's status was suitable to stay at home, or if something happened, whether the navigator thought that they needed to be back in hospital. So again, when patients weren't sure who to call, what to do, instead of coming back to the merge, they would have this one person who could call, who can consult the other team, and then determine you could stay at home. Maybe we need more support. Maybe you need to go to primary care. Maybe you need to see this provider versus coming back in through a merge. And then eventually the navigator would continue to be there, continue to visit this patient, continue to support this patient before they would transition to the local network or home and community care who would provide that ongoing care. The goal of the navigator was never to be with the patient for years or for the rest of their life. It was that when this patient was determined to be more stable and could be transitioned to the appropriate community supports, they would do so. And as you can see, none of this has a timeline because it was meant to really be determined by patient needs and patient experiences. So once the program was up and running, I had the fun part as a researcher to start to develop some research objectives. So my goal ultimately was to inform the design, the delivery, but also the implementation of the Senior Navigator program by providing ongoing and real-time feedback. I was really interested to explore what was influencing the implementation so that we can make recommendations both internally, but for anyone else trying to implement the program, and to really gain insights from key informants on the experiences of working with the navigator or receiving care from the navigator. And so key informants involved patients, it involved caregivers, it involved managers, it involved people who took on the navigator role, social work, etc. And so what was unique about this is that unlike traditional academic research where we kind of had very concrete questions and methods and analysis and we kind of did things sequentially. We were doing things really rapidly. So we were testing things out as we were doing interviews, as I was finding things, as we were doing those design sessions, it informed real life. So for example, when we heard what the navigator should do, that informed the job ad. When we realized we could only really hire one navigator, that informed that. So this was a mixed method study. And in total, at the very end, I had 48 healthcare providers participate in interviews and then 19 patients and caregivers. So 11 caregivers and 8 older adults. And the goal of these older adults was to be the most complex older adults. So while the numbers seem very low, we need to contextualize it and that these were some of the sickest and most complex patients. So a lot of newcomers, a lot of racialized, non-English speaking individuals, a lot of people with mental health, financial instability, etc., who often do get excluded from research and evaluation. So all data was collected through semi-structured interviews, whether they were in person, on telephone, or video conferencing. So again, being very flexible to the needs. And as I said, we did a lot of literature reviews to inform the factors influencing implementation, but also the content. So in the end, we ended up doing 3 scoping reviews and a systematic review. And all this work was informed by the Consolidated Framework for Implementation Research. So this framework is a very seminal implementation science framework, which essentially says that when you do an implementation, you should look at internal factors, outer factors, so outside of the organization, at the individual level, and then also at the more system level. And it was mixed methods because as we were doing this, we were also collecting chart reviews on these patients, all patients who were in the program. And then the qualitative data was analyzed using a reflexive thematic analysis by Braun and Clark, meaning we were considering my role in the project, how closely I was linked, and as well as a phenomenological descriptive analysis. So that's really the meaning making and what was the lived experience like of these folks throughout the program. So as I was doing work, we were kind of giving this feedback back, changing the program, etc., looking at barriers, but some of the overall impact and impressions of the program were huge. And so families and caregivers and their patients often said things like they really felt this was helpful because they knew who to go to, especially during periods of visitor restrictions. Again, noting that this was the pandemic. They couldn't necessarily check in, but they felt really confident that their navigator was taking care of their family member, or if they didn't know who to call just to get that check-in, they would call the navigator. The navigator helped them obtain medical supplies and access primary care physicians by forming those linkages, doing the calls, and putting things into place. And it was also an outlet for the families who really felt that they were also supported. And it was really family-centered care. From the community side, they were telling us things like we're all on the same page. They knew how to monitor their patients who were in the hospital. They were notified when their patients were in the hospital. They knew what was happening, and they were all aware of the care plan. It really helped non-social workers in particular feel confident in the discharge plan. So often they are excluded from the actual plan. They're just kind of told readiness to discharge. So we were hearing a lot of that. And it really helped even community providers know of existing resources that were in their own networks, but oftentimes they didn't have time to be able to come and look for themselves. One quote from a patient in the program was, "The patient navigator is wonderful. I cannot say enough. If it wasn't for her, I don't know what would be happening to me. I don't have children. I don't have a spouse. I mean, my friends are old. So it's just me to take care of me. And because of her, it isn't just me. I can stay home and not be dependent on nurses." Similarly, a caregiver said, "If it wasn't for this program that you have, I'd probably be in the hospital myself. No one ever stops to think about the caregivers, and this program does. Patient Navigator, for me, gave me what I need, and more so, just how I am. She takes that time. No one else does. So they really highlighted that one of the navigator's rules was to ask family how they were doing and what support they needed. From a healthcare provider in the hospital, they said, knowing she or the navigator knew my patient and their medications and experiences made me trust that they would be able to meet their needs at home. So again, this idea that the patient navigator was there from the beginning made the other healthcare providers who often don't know what happens when the patient is discharged feel confident that the patient would be well taken care of. So all in all, the study used really in-depth qualitative methods to evaluate the program in real time and allowed us to conduct real-time feedback. The patient navigator was viewed as being impactful to improving the care journeys of patients and family members, and it provides initial insight to models of patient navigator programs that can be expanded across North America. So taken together, the study really demonstrated that patient navigation models such as this really could help integrate support and accelerate the support provided to older adults, and as well as provide better experiences for the healthcare providers by enabling extra support to their teams and making them feel more confident. By addressing the gaps in services and those poor experiences, particularly during transitions in care, the patient navigation or navigators can contribute to more effective resource allocation within the healthcare system. So again, they're putting the right supports right when they're needed. And so the goal is that this research can really guide future research to explore how do we sustain and scale these models of care. So how do we take what we learned here in Toronto, Ontario, and expand it? How do we sustain the patient navigation model? As I said early on, through providing this ongoing feedback, this program now still is able to run 4 years later. But how do we keep it and make it a more standardized model? But this research or this program didn't answer everything. So we really need to understand what is that patient navigator role. We came up with a laundry list, but really it was the navigator who was nimble and quick thinking. And as we gave them feedback on either what people were saying, they were able to do it. So a lot of this was very navigation or personal to that navigator's characteristics and skill set. But how do we actually develop a good job description for this? And how do we better integrate them into the team? So again, this was a person who worked both in hospital and would go home and work in community. How do we integrate them into both teams when it's such a unique role? So these are some of the unanswered questions. That said, this work was graciously funded by the Slate Family Foundation, who through this work was able to continue the funding of the Navigator program, and then the research component. I was funded by the Alzheimer's Society Postdoctoral Research Program. So with that said, I welcome all questions and comments. Thank you so much for listening.
Thank you, Kristina, for this great presentation and for sharing all of your expertise with us. The floor is now open for questions, so you can ask your questions by typing them in the Q&A box. And I think we already have one question, so let me read that one out. So first question, how does the navigator address environmental challenges that may hinder a smooth transition from hospital to home care? So these may include issues such as pest infestations, limited financial resources for essential equipment, or difficulties in coordinating community support services like meal programs. And then question adds for people who live alone.
Yeah, so one of the unique things of the program is that the navigator actually gets to go into the person's home afterwards. So the person leaves hospital and then the navigator visits a few days later and can see some of those things. So some things like pest infestation, we saw a lot of instances of hoarding. And again, this was someone who worked in the community prior, so was used to some of the stuff and was used to being nimble. They frequently would say, and myself, I'm not a clinician, so they would frequently say to me, you kind of don't know the patient till you go into their house. You don't really know, are they falling because they're dizzy, or are they falling because their room is so hoarded or there's pests, etc. So the navigator was able then to put the appropriate supports in place. So in a case like pests, it would be, say, cleaning supplies. It would be things like government resources. It would be things like even mental health concerns. But the navigator's job in the situation of limited financial resources, which was a bunch of our patients because they were complex care needs, would be to connect them to community services. What was unique to this program is it did have buy-in from Sprint Senior Care as the community agency, and it really did have buy-in through the hospital so that there was already an organization who was willing to put in those services, helping to overcome things such as wait times, etc. But of course, we couldn't overcome everything. There was a lot of challenges due to the pandemic. A lot of primary care physicians went virtual, for example. So the navigator would have to be nimble and do things like attend that person's house, bring their own laptop, sit on the Zoom call with them, make sure that they had the appropriate services. So it was a lot more hands-on care that we would have seen in typical models of care. Um, but it was really up to doing basically whatever we can to meet their needs.
Thank you, Kristina. So we have another question. How were the 19 patients triaged for this program?
Yeah, so in total, we did have more than 19. These were the individuals interviewed for the purpose of the research component. In total, we had over, or to date in the 4 years, I believe it's almost 100 patients. So what made this program unique, but what also makes it a challenge is how do you define medical complexity? So we had a lot of sessions early on where we were trying to get at the definition. So who would qualify for the service, especially when it was very hard for us to staff the navigator role. Even when we had funding, we couldn't really retain staff in the role, except this one navigator who kind of still is in this role today. And that's just because of the difficulty of, as you can imagine, of needing to always kind of do whatever you can for your clients or your patients. So the 19 participants in the study were simply picked based off their ability to consent, their ability to communicate, their willingness. As well, we tried to get more. Sometimes there it was no show. Sometimes these people had very severe mental health needs that an interview could be very triggering and interviews were stopped. Sometimes we lost them to follow-ups. We had a lot of precariously housed individuals who you couldn't, their phones weren't stable, etc., to follow them out in the community. I forgot to mention, but we interview people both in hospital and then 30 days after they left, and then 90 days after to see what their experiences were like. For the patients not interviewed but enrolled in the program, it ended up being really up to clinical intuition. So if the navigator or the team determined that their needs were quote unquote complex. That's how they got enrolled into the program, which is very atypical for a healthcare environment who really likes checklists. We tried, and that was one of the rapid findings of our reviews. We tried to have checklists. We tried to say they need to have these conditions combined with this. It didn't work because some people were still felt that they were complex, and we were hearing a lot of things from our healthcare providers like it's a gut feeling. No, you just kind of know. Or, hey, who's to say this person with 4 medical conditions is more complex than the person with one, but mental health concerns, financial concerns, housing concerns, etc. So that's essentially how we did it. It was open, but unfortunately that did um, had some limitations as well.
I love how this program just grew and adapted to lessons learned
Mm.
rapidly along the way. Um, so there are lots of other questions. So let me move on. What are the resources required to grow this program? So how many patients can one navigator manage at one time, and what qualifications are required to undertake the role of navigator? And
Yeah,
that's
so those
also
are
something I'm curious about how this program has been sustained over like a long period of time. So
so the resources to grow. At the very beginning, I began my talk by saying what was happening in the external environment, but also what was happening at the local environment. So this was hospital priority. We were able to develop a program that kind of met met needs the hospital already had. And when the hospital or some CEO is willing to, that means there's more funding available. We also were graciously supported by hospital, but also community, but as well as a gracious donor from the Slate Family Foundation who really believed in this model and pledged quite a bit of money to this model. Over the years. Initially, it was supposed to be a 1-year program, which is why we did some rigorous academic work as well to try to kind of bribe and make a business case for this. In terms of the resources needed for navigation, as I said, ideally we wanted numerous navigators, especially as funding grew or continued to come in, um, as we were seeing that things were working. It was very hard for us to sustain the role in that there was a high turnover. And it was also difficult to make a job description. From our literature reviews, we found that most patient navigators in other areas and other models of patient navigation tend to be social workers, which is where we started, but as well as occupational therapists. So I did a review on the role occupational therapy can perhaps have. Some people use nurse navigators, and that was what another hospital and a cancer care center in Ontario was doing, right? So we didn't, so we again had to give this information, but best practice kind of said, okay, social work kind of dominating this. Most of the literature is in social work. We went with social work. And then, as I said, we picked someone who was in the community because they felt that they could be that most nimble because they had to. They didn't have the luxury of a hospital. But we still have an unanswered questions. We still really struggled from an organizational standpoint, and I've been hearing through the pipeline, this is still a challenge of how do you go to HR and you say, basically, this is a role for someone who knows patients and knows how to navigate a system and also be very, very flexible because no two cases are going to look the same. No two service providers are going to look the same. You need to know kind of what services are out there. So you need someone who's experienced in those ways. But again, the very concrete skills we're still trying to figure out. And that was an unanswered question by the research.
You sort of touched on this next question a little bit, but maybe you can elaborate on who pays for the service of the navigator. So how much is the navigator paid?
Yeah, so this is surprisingly a difficult question that we also had to overcome. So we had this money come our way to fund the program. We had the hospital pledge some financial resources. We had um, the community center where this person was recruited from. Where do we house this person for HR purposes? We actually initially tried to house them in the community center. Didn't work because that meant legally they could not access the EMR, the electronic hospital records of their patients when they were in the hospital. They couldn't just wander the floors. It was COVID. So we hired them at the hospital level, and that's where they remain and did throughout the program. But the challenge is once they left the hospital, they couldn't access, or the patient left the hospital, they had to basically start a new chart to comply. So a lot of what the navigator did, which is not very pragmatic or cost savings, is chart both in the hospital electronic records and chart in the community records so that they would always kind of have a consistent records. It was something we couldn't overcome just with privacy laws, etc. The navigator was paid for by the Slate Family Foundation donation. As terms of their salary or how much were they paid, I can't quote exact numbers, but we paid them. Unfortunately, learned along the way that community social workers tend to make less um, than hospital workers, and we paid them kind of in that middle ground per our kind of donor agreement. But I wasn't involved too much at the human resource levels.
Another question. Have you considered adapting the navigator model to incorporate it into social work training? So, for example, placements to help sustain staffing while creating an opportunity for real life hands-on experience for those training to enter the field to address the growing need for professionals supporting seniors as they navigate the healthcare system.
Yes. So if you read some of our scoping reviews, particularly the one around who should be the patient navigation, we do make, or at least I make the argument that it should be incorporated as a potential career option and or service um, model, both for social work and occupational therapy. But has this actually been implemented to the best of my knowledge? No, despite being at the University of Toronto and working with the department on the role of OT and presenting on the role of OT in patient navigation, it is not. Um, and part of this complexity is when we say the term patient navigation, which has really caught wave across Canada as a model of care. Not all models look like the senior navigation model, where someone works both in hospital and also goes to their homes. So it is kind of a unique model, but there's so many different models that I think just generally introducing the model of care of navigation and introducing transitions in care is kind of what I've well advocated for.
Thanks, Christina. So we have another first a comment. Great presentation, Christina. Were there any challenges encountered with regard to change management and getting buy-in within teams as new processes were being introduced, and how were these overcome?
Yeah, so as much as it was hospital priority, we need to remember that this work was being done and implemented at a time when a global pandemic was happening. What we frequently heard as well from people was, we're just going to get a bunch of money. The hospital's very notorious from getting money. They do a program for a week, a month, a year, and then it dies out. So that's why really I learned very early on that if I was going to get buy-in, I needed to prove that we were doing everything we can to have some sustainability, because people were really tired of coming, giving their thoughts, being involved in work, learning new models of care, learning new referral practices, and then a year later, the program was defunded by the government, defunded by the hospital, not priority. So that's how come we took on that rapid approach too, and we made sure that all our knowledge translation was going both to hospital leadership, community leadership, but also our donors to try to just kind of sweeten the offer when we put in the business ask at the end. So that was one of the biggest challenges initially was, who are you? We have a global pandemic. Yeah, right, this is going to last very long. Um, Also, when I left my postdoc, ensuring that another postdoc say was in place to continue navigating new models of patient navigation. So say a housing navigator, et cetera. So really embedding research and evaluation throughout as well really helped me try to get people to enroll in the study component and not just the design component of this work. And then we had challenges related to buy-in, as I said, as to getting people to take on the navigator role. We had people interview, post, but burden was very high. This was also a time period where if you were a frontline healthcare provider, you could almost have any job you want. And these weren't necessarily the most high-paying jobs in the hospital, the easiest jobs. These are jobs asking you to risk your health to go into people's homes, precarious housing situations, etc. So we did even struggle to get buy-in at the navigator role. But as I said, so much of the success of the program was finding kind of the right fit and someone who really took it on to go above and beyond to learn, to do everything that they could in their skill set. And um, overall, to help buy-in or to overcome, is we were sharing these lessons publicly. So instead of saving everything for an academic paper, we were doing one-page briefing notes that would go out in a blast email. We were doing kind of lunch and learn sessions where it would just be Tim Hortons coffee, which again, during the pandemic, people were having lunch by themselves, right? We couldn't engage the way we typically could, but just kind of putting a briefing note with the Tim Hortons cup of coffee kind of sometimes helped as well. So I was hoping as we saw some type of successes, especially at the beginning where we didn't. At the beginning, we were struggling with, okay, what is medical complexity? And that was failing, and we weren't getting the right referrals, and we were declining people, or the navigator wasn't able to do certain things. The program wasn't always as success as it may seem. So especially in those times, just keeping and saying and reinforcing that we are learning, we are evaluating this. So I did things like make sure I was present at the hospital during this time, that my supervisor was, so we can again prove we are trying to make things work and hopefully get buy-in. But it was a slow process. This was over an 18-month period. month. period. 18 month. period. 18 month. 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 18 month.
So we have another question around, is the Navigator program similar to emergency management nurses at the hospitals?
So I think the difference here is that the navigator actually follows this person home and is able to stay with that same person from the point of entry up to the point of discharge, and then visits the patient in the home and can be with the patient for up to 90 days after. So it's a much longer and continuous process.
Thank you. What was the type of collaboration community? Uh, were they
Yeah, so Sprint Senior Care was the partner organization who did provide direct service. They were also brought in as a stakeholder in this. So they attended all our co-design sessions because they really represented the voice of the community. So we engaged a lot of their staff as well, who were used to going into homes, being community social workers, to kind of let us know, as being in the hospital more so, what happens when people go home. But they did provide direct services of care. So essentially, their mandate as part of this was to make sure that some of the services they provided, connections like Meals on Wheels, et cetera, would be able to go to our clients and the patient navigation families.
so I was just informed that my audio was cutting at the specific time
Mm.
repeated, but you don't have to repeat what you said, Christina. But just for those that weren't aware of what the question was, is uh, what was the type of collaboration with Sprint, your community provider, and were they the direct service of care? So that was the question. Now I'll move on to the next question. How does the patient navigators liaise with the scope program?
Yeah, so they did only as appropriate. So the patient navigator was nimble or flexible. The role was flexible that they could liaison with anyone they needed to, essentially, was the mandate. So these can be people with Sunnybrook who could, who couldn't. Of course, we ran into barriers. Sometimes it was out of catchment, etc. Um, but they didn't, Scope was not, say, one of the key partners, although I bet many members of them did come to our consultative exercises.
Grounded residents in long-term care do not come with family or a circle of support. What role would a navigator?
Yeah, so a lot of the clients in the program, a lot of the clients that Sunnybrook did see are these individuals. So, as the one quote I shared was from an individual who said, I didn't have family, I didn't have friends, and I didn't have a spouse. So, the navigator really was able to play that role in connecting them to things like social support. If loneliness was a concern, the appropriate resources, assisting them with something as simple as setting up their computer so they can go into Zoom, lending them out iPads from the libraries, etc. So the navigator essentially played that family caregiving role when family was absent by being that one person to check in at the hospital, to being that one person to call out and simply ask, how are you doing in all this? Do you have questions for the physicians? Do you understand what's happening? What do you need? Not just again from that medical lens that typically happens.
Thanks, Christina. There's no questions, but I might have one for you. And we do a lot together, so I think it's the appropriate question for you. And so I love how this provides support for care. And I'd love for you to elaborate on, the extent, or if you've heard, like, I know there was one quote around, if you can provide more insight into how this, because we know that if caregivers and family members don't take care of themselves and their family member, and so how does this, also support uh, family members?
Yeah, so I know the audio is just a little choppy, but I think the question is how does this program, can you elaborate more on how does this program support family caregivers? And so really it was a unique time because these were the people allowed in the hospital who could communicate with family, especially when family was not always invited in to some of the services, especially during visitor restrictions. So people often said that the navigator, from building that trusting relationship, from being there from day one and knowing that their role was to advocate for the patient's need, really filled in that gap. Whereas a lot of what family caregivers do is that advocacy role or that communication role of bridging the gap between providers. So, as the one participant said, the navigator was who they couldn't be. Family caregivers were also well supported because the navigator's role was to help them sustain their caregiving role. So they were often asked as well, how are you and what do you need? And the goal of that was because when a lot of these individuals who do have family are discharged home, it's the family caregivers who are unprepared to take on that caregiving role, but are expected to fill that role. So remember, these are people who come to hospital, are admitted, and are now going home with things like medication needs, rehabilitation, exercises to follow. And no one, it's not standard practice in Ontario to train the caregiver on how do you caregive. So the navigator was able to put those supports in place, things like respite care, things like um, advocating. So it was as simple as these are your rights as a caregiver for taking time off work, right? These are the legislation, or this is what some strategies you can do to take care of yourself. So again, using kind of some of their resources, but also relieving that burden on families. So oftentimes it was these caregivers who typically come into hospital, they're writing down all the documentation, they're calling primary care, they're calling to try to get or navigate the system of where do I find rehab, where do I find appropriate home and community care. So the navigator took all that because the navigator knows the system. So they kind of know who to call, what the wait lists are, what are the requirements. And we're able to be that one person that the caregiver could ask questions. But I would say, um, what I think the biggest role was simply just helping the caregivers be seen, be part of the team, and asking that simple question of how are you doing in all this?
Thanks again, Christina, for a great presentation, and thanks for talking more about this super important. I hope will continue for a long, long time. And thanks for everyone for attending the webinar today. Just as a reminder, there will be the recording of this session shortly on the Center of Excellence website. Have a great afternoon, everyone.
Thank you all for listening.